Hello, future nurses. It's Professor Flourish. Today we're going to be talking about concepts of fluid balance and imbalance. Now, before we begin, we're just going to go over some general concepts. A lot of these things are things you may have learned in your anatomy and physiology class, or even some things that you learn in your fundamentals. And what I will say about these general fluid concepts, take it with a grain of salt. A lot of these concepts we build on later as you continue on in the program. So if you don't completely grasp it, that's okay. All right, so the first thing is balancing fluids, the importance of water. So one of the main things is that it helps us regulate our homeostasis. So homeostasis is how equal we are within our body and how stable our body is. So some of the things that fluid does is maintain body temperature, cell shape, transportation of nutrients, gases, and wastes. So that's one of the things that it does. Most of the body's major organs work together to maintain these fluid balances, which we'll talk about as we continue on, but a lot of our bodies work together to kind of regulate to make sure that we're in a state of homeostasis. So these are just some general consideration. 60% of young adults' body is water. Older adults, like we talked about last week, we always want to make sure that we're taking consideration with our older adults. Older adults have less than 50%. What does this matter? Or why does this matter? What does this place them at higher risk for? This is why for our older adults, if you remember what we talked about in chapter 4, it was all about cognition. A lot of them, their hypothalamus doesn't regulate that they're thirsty. So since there's a delay in that, they don't know they're thirsty, they're more inclined to become dehydrated. And since they're already starting out with less water, it puts them at a higher risk for that. Infants are between 70 to 80% water. The amount of fluid gained through intake must equal the amount lost. So however much you're taking in, you want to equal to how much you're losing. Electrolytes, which we'll talk about later this week, are chemicals that conduct electricity when dissolved in water. Oops. Fluid loss. You have two types of fluid loss. You have insensible losses as well as sensible losses. So insensible losses are things that we can't really measure. So that would be basically like our skin. If we sweat, you don't really get like a beaker and collect somebody's sweat. So that's how we would lose some of this fluid. Another one is sensible loss. These are things we measure. So all these things here, urination, defecation, and wounds, those are all things that fall under the nurse's responsibility. So as the nurse, whenever it's something that is my responsibility, those are things that I want to know what's going on with my patient. Are they urinating more? Are they urinating less? There are different fluid compartments. We've got intracellular fluid and extracellular fluid, which I'll talk about more as we continue on. And then we've got the capillary walls and cell membranes that separate the intracellular and the extracellular fluid. And once again, both of these things have to be balanced. Your intracellular needs to be balanced with your extracellular. Like I said, water is found in these three different compartments. We've got intercellular, so that's inside the cell, extracellular, outside, and then interstitial, so you will have some fluid that's kind of in between the area. And see, that's in between the cells here. So intracellular fluid inside the cells, intra within, plus cellular cells. So it literally is telling you inside cells. And you can see here, that's that fluid we're talking about. And this becomes important when we're talking about tonicity. So when we're talking about the kind of fluid we want to give somebody, because depending on which disease process they have, some fluids may work better than others. The patient may not have as much albumin, so we may not want to give them just straight fluid because they're not going to be able to keep it in the vasculature here. So those are the kind of things you want to think about, and that's why we teach about intracellular versus extracellular. Um, Extracellular fluid is fluid outside the cell, extra outside cellular cell. You've got the interstitial, so that's the inter between, stitual is tissue. So that literally means in between the tissues. So this is fluid that surrounds the cell, which is 75% of fluid. Then you've got the intravascular, intra means within, vascular means blood vessel. So that's fluid or plasma. that's inside the vein. Transcellular fluid, trans is across, cellular is cell. Fluid in the cerebral spinal column, the pleural cavity, the lymph system, the joints, and the eyes. You don't typically have significant gains and losses. So that's why we don't talk about this one as much as we talk about if we're having a major loss in our vasculature, like bleeding a lot, or we're losing a lot of this tissue that's in between, or a lot of this fluid that's in between the tissues. So control of fluid balance. Primary control of water in the body is through pressure sensors in the vascular system that stimulate or inhibit the release of the antidiuretic hormone. And we're going to talk about more of what controls it. This is just usually the primary thing that is controlled. That comes from your pituitary gland. So this is where I talk about if you have a patient who has neuro problems, then they can have this thing that's called syndrome of sorry, they can have SIADH. Sorry about that. I started getting a cough. Anyway, so what you can have is if something happens to their pituitary gland, and you'll learn about this in MedSearch too, they can have the syndrome that's SIADH, syndrome of inappropriate antidiuretic hormone, where basically they have too much of this antidiuretic hormone. And if you think of diuretic as a substance that causes the kidneys to excrete more fluid, ADH works in the opposite way. So ADH is a hormone that causes kidneys to retain fluid. When ADH is released, water is retained. So that's one of those measures that's used to control fluid balance. So the other thing is this movement of fluids and electrolytes in the body. Fluids move through both active and passive transport systems. So active systems require ATP. So ATP you probably talked about, I think is it Anatomy and Physiology 2 maybe? Or is it 1, the Krebs cycle? Anyway, ATP is just energy for movement. They can be moved, they can move a substance from an area of lower concentration to an area of higher concentration. That's why I have these people like pushing the world up through here because they're excreting, they're using energy in order to actually push this uphill. An example of this is the sodium potassium pumps. How sodium potassium move to and out of the cells. It takes energy to push something uphill. And like I said, this is why our sodium potassium, what's it called? Why these electrolytes are very important. They kind of seesaw each other. So if I have high potassium, I'm going to have low sodium, and vice versa. So the sodium potassium pump, sodium, the main electrolyte that's located in the extracellular fluid. So this assists in the maintenance of fluid balance and osmotic pressure. So sodium is in that extracellular fluid. Potassium is the main intercellular electrolyte, and it assists in the maintenance of neuromuscular excitability and acid-base balance. So in a nutshell, if you're really trying to look at this sodium versus potassium, sodium lives outside the cell, potassium lives in the cell. And this concept becomes very important later, especially when you talk about massive cancers that just build up with a bunch of electrolytes and there's a bunch of potassium. And when that tumor actually breaks, then all that potassium ends up going into the bloodstream. So that's why we get really worried about when we have high concentration of potassium in the blood, because that potassium, its home is supposed to be in that intracellular compartment. It's not supposed to be in the vasculature. This is, sorry. Okay, this next video here is just like a 2-minute video. I have it on Momentum, and you're free to watch it if you want to, but it basically just goes through the sodium potassium pump. And like I said, you don't need to be an expert on it, but just understanding that when one goes up, the other goes down. And whenever we move potassium out of the cell and it goes into the bloodstream, then you can have passive transport, no energy required. Things naturally move towards equilibrium. So one of the passive transports we have is diffusion, movement of a substance from an area of higher concentration to an area of lower concentration. See, I've got all these people like falling. An example would be pouring your creamer into your coffee. Eventually, the cream will spread everywhere. It would be faster if you used a spoon or you spun it, but it will continue to disperse even without the introduction of a spoon. So eventually, everything's going to diffuse. So that's why they give that imagery of the cream inside the coffee, because all the cream is going to eventually disperse into the coffee itself. Filtration, movement of both water and smaller molecules through a semi-permeable membrane from an area of high pressure to an area of low pressure. Hydrostatic pressure, the force that promotes filtration. So the way I remember this one is water pushing force, because you got hydro like water. So this is the water pushing pressure. It is a force that water exerts, helpful in the movement of water, nutrients, and waste products in the capillaries. And I've got this other slide on hydrostatic pressure. And I like this picture here because it gives a very good visualization of there's that hydrostatic pressure. That's that pushing force exerted by water in the bloodstream. The heart's pumping action is the source of hydrostatic pressure, exerts an outward force that pushes water through the capillary membranes, pours into the interstitial and the intercellular compartments. So basically, this is moving from extracellular into intercellular. Then you've got osmosis, which is the movement of water from an area of lower concentration across a semi-permeable membrane to an area of higher concentration. Power pull of water towards an area of higher concentration is its osmotic pressure. Osmolarity refers to the concentration of the substances in the body fluid. Osmotic pressure, and once again, I like this visualization. By far, this is probably my favorite picture that shows osmotic pressure. Pressure exerted by the solutes in solution in the bloodstream. Osmotic pressure is exerted by electrolytes, mainly sodium ions and proteins, so like albumin. Osmotic pressure is a force that pulls water into the bloodstream. So you see how it's pulling it in from the intercellular fluid and the interstitial fluid. Osmotic pressure opposes hydrostatic pressure. So you see how hydrostatic pressure is pushing outwards, osmotic pressure is pushing inwards. This is another kind of video that might help you too with it. It's not very long, but I also put it on Momentum. So autonomic pressure, I don't know why the R is up, also called colloid pressure, refers to the force exerted specifically by albumin in the bloodstream. So if you remember back in pharmacology, albumin is basically what keeps the blood inside the vasculature. That's the whole goal of albumin. Total albumin in the bloodstream is indicative of protein nutritional status of the body. So thinking about this, what happens to the body with low serum albumin? What happens with high serum albumin? And this right here is kind of like almost like a spoiler of what might happen. But kind of thinking about if I've got a whole lot of protein, what is going to happen? If I have decreased protein, what is going to happen? So hypoalbuminemia, low albumin in the bloodstream causes low it causes low oncotonic pressure, and this pressure is lower than the hydrostatic pressure at the capillary membranes. This condition results in edema. So basically what's happening is instead of the fluid being inside the vasculature, it goes into the tissue space, and more or less you just get edema. So that's the issue with having a low amount of protein. On the flip side of this, you don't want too much albumin because then you'll end up, or too much protein, depending on what's the etiology behind your patient, because this can cause too much fluid inside the vasculature, or it can be very hard on the kidneys, which is something we'll talk about later. Tonicity refers to the amount of solutes in a solution compared with the amount in the bloodstream. So we've got three different types. We got isotonic, hypotonic, and hypertonic. So isotonic is basically the same tonicity as blood. So this is like your sodium chloride, lactated ringers, anything that's basically what you give is what you get. So I like this picture here of isotonic. They show the H2O going into the cell at the same rate that it's coming out. So there's not really, you're not really losing, you're not really gaining. So this is great for somebody who has dehydration because they just don't have enough fluid on board. So it's a good solution for that. Hypotonic, less tonicity than blood. So this means that I'm trying to give fluid to a cell that's been completely depleted. So this is helpful for if I've got a patient who has some sort of dysfunction with their vasculature. So they're like a kidney patient or something, or a liver patient. And I don't want to give them more fluid because their body can't process all the fluid, but their cells are dehydrated. So this works very well for those types of patients. Then you've got hypertonic solution, which basically squeezes out all of the H2O from cells. What I will say about this is you always, always, always want to make sure you know what your patient's blood pressure is if you're using a hypertonic solution. Because anytime I've used a hypertonic solution, these patients basically just pee and pee and pee, and they can go into hypovolemic shock very quickly. So I want to know what is their blood pressure before I start out while I'm giving it to them. Crystalloids and colloids. Crystalloids, best way I can think of to describe it, are volume expanders. These crystalloids just contain electrolytes but lack large proteins and molecules that are found in colloids. They're basically classified according to their tonicity. So these are things like your normal saline, your 3%, your lactated ringers, so on and so forth. General rule of thumb is that only 25% of crystalloids will remain in the vasculature, so a lot of them end up moving somewhere else. Then you've got your colloids, solutions that contain large molecules to provide oncotic pressure. Albumin is by far the most common used colloid. So these are basically like with albumin, a protein that's going to keep things in the vasculature. So these are things that we're giving it so that way the fluid will move and stay in that bloodstream. All right, so now we're getting into maintaining fluid. So fluid homeostasis is maintained by osmoreceptors, antidiuretic hormone, the renin-angiotensin-aldosterone system, and and natriuretic. So those are the hormones that are also in your heart. So the first one we're going with is the renin-angiotensin-aldosterone system, or the RAS system. So basically what happens with the system is there's a decrease in circulation or decrease in blood pressure sensed by the kidneys. So the kidneys are like, oh no, everything's decreasing. So what they do is they secrete renin, which stimulates the liver. The liver then releases angiotensin, tells the lungs to convert that to angiotensin 1. And then angiotensin converting enzymes pushes that from going in from angiotensin 1 to angiotensin 2. And this is where most of our ACE inhibitors work, is we stop this conversion here. Now, when that happens, it stimulates the peripheral arteriole to cause vasoconstriction. And whenever you have vasoconstriction, that is an increase of blood pressure. And that stimulates the adrenal gland to release aldosterone. And all of this results in increased blood volume and increased blood pressure. So if I've got some sort of issue with my adrenal gland, or I've got some sort of issue with my kidneys, then I can have an issue with how I regulate my fluids. That's the picture there. And then once again, I've got another video about it that you can see online. The nitriureas is an excretion of large amount of both sodium and water by the kidneys in response to excessive extracellular fluid. So a lot of these we consider are our blood vessel or our heart sort of hormones. We've got ANP, BNP, and CNP. And so I was talking about that BNP produced mainly in the heart's ventricles. Okay, so the first thing we're going to talk about is dehydration. So dehydration is the lack of fluid in the body from insufficient intake or excessive loss. You can have actual dehydration, which is the lack of fluid in the body. Relative dehydration involves a shift of water from the plasma to the interstitial space, or hypovolemia or isotonic dehydration, which is the lack of both water and electrolytes, causing a decrease in circulating blood volume. This is also called fluid volume deficit. So that's where you can have different types of dehydration. Now, like I said, dehydration is that state of diminished water volume in the blood, deficiency of the intercellular fluid, body cells begin to shrink, decrease in the amount of water in the extracellular fluid, osmolarity of the blood increases, which causes increased thirst, ADH releases, RAS activates. That's why I talked about those different systems, is my body sees, hey, there's a decrease in volume in my vasculature. We need to do something to correct this. Some of the causes can be things like reduced fluid intake, excessive fluid loss, lack of ADH production, uncontrolled diabetes, and hypernatremia, which on the next two slides, I'm going to kind of talk about that uncontrolled diabetes as well as hypernatremia. Which hypernatremia, we're going to go into more detail later. I just kind of want to talk about it so you get a small understanding of it before we go in. So hyperglycemia of uncontrolled diabetes. Glucose increases osmotic pressure. Osmotic pressure is greater than hydrostatic pressure. Because remember before they were supposed to go at the same rate. Now they are not even. Water is pulled from the intracellular fluid to the extracellular fluid. Uh-oh, now we got all this fluid that's no longer in the cells, and instead it's in the extracellular fluid. Cellular dehydration occurs. So if I've got cellular dehydration, is an isotonic solution going to help this patient? So just like pause for a second and think about it. Isotonic, it's going to be the same either way, correct? Yes. So instead, a hypotonic solution would probably be better because I'm trying to fix cellular dehydration because I want something where the fluid's going to go into the cells instead. That's why sometimes you might see them order something like half normal saline instead of just normal saline. More water to the kidneys. So because it's in that all extracellular space and since it's going potentially in the vasculature, then it causes excessive urine, polyuria. So that's kind of on a cellular, I guess, scale. That's why patients with high glucose will end up peeing so much. Then we've got hypernatremia. Sodium increases osmotic pressure. So this is similar to what we just talked about. Osmotic pressure is greater than hydrostatic pressure. Water is pulled from the intracellular fluid to the extracellular fluid. Cellular dehydration occurs. Excessive fluid in the ECF is excreted via kidneys, further dehydration. So that's why if I have a lot of sodium on board, I can actually make my patient very dehydrated. And this is just dehydration or hypovolemia. So I've got dehydration. This is the things in my body that are going to do something about it. We talked about it briefly. This is just in more detail. Stimulation of the osmoreceptors in the bloodstream, stimulation of the thirst center and the hypothalamus in the brain. Now, what I always say with these osmoreceptors, always think about your older adult. Older adults may have decreased cognition, they may have decreased ability to use their hypothalamus. So for your older adult, are they always going to know when they're thirsty? Near the Dora the Explorer, pause the movie for a second. No, they're not going to always know when they are thirsty. Then you've got the stimulation of the peripheral baroreceptors in the blood vessels, sympathetic nervous system. So that causes vasoconstriction. Stimulations of kidney to secrete renin. So the RAS system raises blood volume and blood pressure, and then stimulation of the osmoreceptors. stimulation of the posterior pituitary gland of the brain, which causes the release of antidiuretic hormone, which causes water reabsorption at the nephrons of the kidneys. So with all that vasoconstriction. And we'll come back to this when we're talking about our signs and symptoms because they kind of relate to all these different aspects here. So what are our risk factors? So what are some causes of dehydration? Hyperventilation or excessive sweating without water treatment. So if you've got somebody who is sweating a lot, then they're going to have that insensible loss of fluid. Prolonged fever, prolonged diarrhea. Now, diarrhea, you really do have to watch your patients for diarrhea because it can cause a fluid imbalance as well as an electrolyte imbalance. So make sure you're watching them. Diabetic ketoacidosis. Once again, when we think about what happens on the cellular aspect of diabetes, we've got this patient whose osmotic pressure is not on the same rate as their hydrostatic pressure, and all that fluid from their cells is going outwards. They're peeing a lot. They can become dehydrated. Diabetes insipidus. Diabetes insipidus is an endocrine issue, and it's going to cause them to pee a lot. Osmotic diuresis. So if I give somebody 3%, if I give somebody a mannitol, it's going to make them pee. Excessive intake of salt, hypertonic solutions, insufficient water intake. So a lot of times that would be things like I'm giving tube feeding without water administration. That's why you always want to make sure you set up your tube feed correctly. Decreased thirst sensation, and then if they're just not eating. And then here are some more: excessive GI loss, vomiting, NG suctioning, diarrhea, excessive skin loss, diaphoresis without sodium and water replacement, excessive renal system losses, third spacing, hemorrhage, altered intake, anorexia, nausea, nothing by mouth, confusion because they're not actually eating or drinking like they should. Then we've got our signs and symptoms. Obviously, thirst. They've lost a lot of fluid. Their hypothalamus is going to say, hey, I'm thirsty, so they should feel thirst. Now, what I will say is older adults don't always feel thirst, so you have to watch out for them. Dry mucous membranes. Always look at your mucous membranes to see, are they dry through here? Or skin turgor. Tenting of the skin, that's an assessment data. Decreased blood pressure, low urine output, dark colored urine, and newborns depressed fontanelle, thready increased pulse rate, diminished peripheral pulses. So why do I have an increased pulse rate but a low blood pressure? Take a moment to think about that. Homeostasis compensation. Basically, my heart is trying to beat as fast as it can so I can get whatever it can to get into the peripheral area so that way I can perfuse. So that's what you'll see, and you have to really watch for that because you don't want your patients to go into shock. Now, these are all signs and symptoms. Do you think that you are responsible to know all of these? Absolutely. And why are you responsible to know all these? Because you want to catch it early. Because if you know that somebody has signs and symptoms of dehydration, you want to communicate with your healthcare team to find out a plan so that way we can get fluids on board for them to fix the problem. And until you get fluids, first thing you want to do, go ahead and put them as a falls risk because they're probably going to get confused. Oliguria, urine production is lower than 400 mLs per day or 20 to 30 mLs per hour. Honestly, you're not having good kidney function if it's under 30. So one thing that NCLEX loves to do is give you something that shows that it's less than 30 mLs per hour because they want to make sure you know that that's a big red flag that they're not having enough urine production. This amount of filtration is needed to sufficiently excrete waste products from the blood, often indicates dehydration or kidney disease. Assessment of fluid status, daily weights. Honestly, daily weights is a great way because no matter how much you eat at Thanksgiving, you're not going to gain like 20 pounds. However, you can gain quite a bit of weight from fluid, like holding on to fluid. So you want to make sure that you're watching your patient's fluid how much weight they've gained and how much weight they've lost. Is our treatment plan working? 24-hour intake and output, and your vital signs. There's a reason why we teach you vital signs first. It's the most important thing to know what's happening to your patient. So some expected findings. So these are some more signs and symptoms, and I have these on here quite a few times. Vital signs: hyperthermia, so increased temperature; tachycardia, an attempt to maintain that normal blood pressure; thready pulse; hypotension; orthostatic hypotension. So that's where we have to think about, okay, I know that they have orthostatic hypotension. What can I do to prevent them from falling? Falls precaution: decreased central venous pressure; tachypnea, increased respirations to compensate for lack of fluid volume in the body; hypoxia. So they're trying to compensate, so they're going to be breathing harder. This can end up putting them into having not enough oxygen. Neuromusculoskeletal: dizziness, syncopal, confusion, weakness, fatigue; gastrointestinal: thirst, that dry mucous membrane again; nausea, vomiting; renal: decreased urine output. All these things are things you want to look for. Diminished capillary refill and dehydration. Client can have elevated temperature. Rapid or severe dehydration can induce seizures. So looking for those things like, do they have decreased urinary output? Are they hypotensive? Do they have dry mucous membranes? Do they have poor skin turgor? And yes, you absolutely want to know with dehydration. I've said it on here several times to kind of get it into this idea of, you need to know what your expected findings are, what your signs and symptoms are, what your patient's going to look like if they're possibly dealing with dehydration. Effects of fluid imbalance in older adults. Yeah, there's my older adult. He's over 65. Again, he's like, I don't know. Anyway, so the effect of fluid imbalance in older adults is greater. Remember, they're starting out with less fluid. They have loss of sorry. Their skin isn't as elastic. Decrease in glomerular filtration and concentrating ability of the kidneys; loss of muscle mass. Muscle tissue holds more water; and diminished thirst reflex; decreased cognition. Now, the thing about it is, you can have somebody who's completely cognitively aware. So you can have somebody who's like 90 years old and they are perfectly fine, they're perfectly with it. If they're perfectly fine, perfectly with it, then you don't have to worry. What you're really looking for is, are they over the age of 65, and what is their cognition like? Because if their cognition is impaired, then I'm concerned to, hey, you're going to be at a higher risk for having dehydration. So a lot of times when you're looking at who's at the most risk, you got to look at first the age. So you have to look at who's over 65, because that puts them at a higher risk already. So you get one little tab for risk factor. Then next you have to look at, okay, I know these are the people who are over 65. Next you have to look at, what other comorbidities do they have? Are they able to make decisions? Are they able to not make decisions? These are some of your laboratory tests. Hematocrit is increased in hypovolemia. BUN has increased. Your urine specific gravity is greater than 1.030. A urine concentration test. So your urine specific gravity is a concentration test that provides specific gravity of your urine and measures your kidney's ability to balance water content and excrete waste. Basically sees how heavy or how many solutes your urine has. Blood sodium greater than 145 with dehydration. Blood osmolarity greater than 295 with dehydration and hypernatremia. Now, what I will say is NCLEX will usually give you these normal ranges. You just need to kind of be aware of what to look for, because the range will be there because they're not trying to test you on exactly knowing this range. It's, what are you going to do now that I know that this patient is in an abnormal range? Because if it's greater, I've got a high urine specific gravity, I'm thinking of dehydration. So now I need to think of, what can I do to fix this? Which is on our next slide. So nursing actions, provide oral or IV replacement. Remember, we always start with the least invasive thing to do first. So least invasive thing to do is try to get them to drink some water. If they're cognitively impaired, just remind them, hey, here's a glass of water. So that would be like best practice. Now, the first thing I'm going to do before I do anything else is if they're confused, especially if they're confused, I'm going to make sure I initiate that fall precautions. Make sure they are safe. Safety always comes first. So they are safe, then I can move towards these other things. So I'm going to provide oral care or provide oral water, I guess. And if that doesn't work, we get it to be more invasive with the IV replacement. I'm going to monitor my eyes and nose. So that's my assessment stuff. I'm going to monitor my vital signs. Monitor for cognition. Remember, the more they get dehydrated, the more likely they are to have mental status changes. So you want to watch that. That's why I say initiate your falls precautions as needed. Monitor, wait, it's supposed to be, hold on, let me fix how that looks real quick. My goodness. Monitor weight, not weight. Sorry about that. Assess level of gait stability, safety. Encourage patient to change positions slowly, rolling from side to side or standing up slowly. And then let's say that we did everything right, but our patient is still dehydrated. So these are some of the complications that can arise if we do not correct it. And that is hypovolemic shock. So when does this occur? This occurs with significant loss of body fluid. The client's mean arterial pressure decreases, so that's their MAP, which slows blood flow and perfusion to tissues of the body, and the cells are no longer able to carry oxygen to the blood adequately due to the loss of RBCs. The main clinical sign, and the reason I teach this, because you'll learn about shock in more depth when you continue on in the program, but I want you to be able to know that if all of a sudden you see that your patient has a very, very low blood pressure and a very, very high pulse rate and their heart rate's very elevated, start thinking shock and let your clinical instructor know. That's a very important sign to know that things are not going well for your patient. And realistically, the whole reason we keep patients overnight, the whole reason we watch them at the hospital is to watch for them going into shock. We want to keep them safe. So what can we do for this complication? Volume replacement is essential. So making sure that we're giving them replacement of fluids, administering oxygen, because with that lack of perfusion, we start impeding on our ability to have adequate oxygenization. Stay with an unstable patient. I cannot stress this enough. If you don't feel safe with what's going on, don't leave them by themselves. Monitor vital signs every 15 minutes, provide fluid replacement as needed, assists with the administration of vasoconstrictors to improve myocardial perfusion, and maintain hemodynamic monitoring. Now, all this stuff here, these nursing actions for hypovolemic shock, there's stuff that's like I said, you'll get that in MedSearch 3, so that's a lot more advanced. But the main thing I want you guys to know is if you see that low blood pressure, high pulse rate, that's that big red flag. This is just because some of you guys like the continuation to know what to do. Evaluation. So now we have to ask ourselves, did our patient get better? Getting better are positive signs. These are things like, did they get better? Do we see decreased symptoms? Are they have less orthostatic changes? Do they have stable blood pressure? I want to see that my patient got better. I'm no longer seeing them be confused. I'm no longer seeing them have these orthostatic changes when they stand. Or did my patient get worse? Your negative signs. Do they have increased fluid loss, worsening symptoms, increased confusion? Do they have an increase in their orthostatic changes? So you just want to be able to look at all your signs and symptoms and ask yourself, what is a good sign that things are getting better and what is a bad sign that things are getting worse? Okay. So the next thing we're going to talk about is overhydration. So some common signs of fluid volume overload or some common causes of fluid volume overload are heart failure and syndrome of inappropriate antidiuretic hormone. I've got some other ones on the next slide, but I wanted to talk about these ones and just explain them to you very quickly. So heart failure, what happens is you have low cardiac output, stimulates the RAS, which causes excessive water into the bloodstream, which causes increased hydrostatic pressure, which causes edema and infusions. We'll talk about what this is to these pulmonary fusions in just a bit. Syndrome of inappropriate antidiuretic hormone, excessive antidiuretic hormone acts at the nephron, too much water reabsorption into the bloodstream, dilutes the blood, diluted hyponatremia. Other causes, kidney disease, inadequately controlled IV therapy. So you can also, it's like back when they used to say you can prevent wildfires. It's like you can prevent fluid volume overload by watching your IV therapy and excessive sodium. So what are my signs and symptoms? Edema, weight gain, full pounding pulses, distended neck and hand veins, elevated blood pressure, moist crackles on auscultation, increased urine output, third spacing, ascites. So looking at this, what is my number one sign that I am most worried about? Moist crackles on auscultation, because that implies that there's some sort of breathing problem. All of these are concerning, but when we use our ABCs, that's what I'm concerned about. Distended neck veins, whenever you have distended, you always want to look at those jugular veins because that means that I've got a bunch of blood or a bunch of fluid building up. How does edema occur? Edema occurs when there is an excessive amount of fluid in the interstitial fluid and in the intercellular compartments. It can occur because of elevated hydrostatic pressure created by excessive water in the bloodstream or diminished osmotic force, creating a low amount of solutes in the bloodstream. So if you have protein starvation, it can cause them to develop edema. Pitting edema occurs when the pressure is applied to the small area and an indentation persists for some time after the release of pressure. Depending on the severity, an individual can have +1, +2, or +3 pitting edema. Third spacing, this is what I was talking about before. So basically what third spacing is that during illness, fluids can become Sorry, I do these in my office sometimes, and if people come in, I get distracted. So basically with third spacing is that the fluids will move in different body cavities. So they go into places that they usually aren't in. So for example, you can have ascites in the peritoneal cavity, or you can have fluid around the heart and the pericardial. So that's where you have pericardial effusion. The normal heart, you see how the pericardium is where it needs to be, and then it moves outwards here. The fluid that accumulates in these cavities is commonly called effusion. So, like I said, basically what happens is a lot of this fluid diffuses out through this way, and then it gets stuck in this buildup here, and that can impede on the normal functionality. Like for the heart, pericardial infusion can actually be very deadly if we don't remove this fluid because my heart's not able to pump the way it should. That's just basically in a nutshell what third spacing is. Overhydration, health promotion, and disease preventions. When your patient has a known heart disease and impairment of kidney functions, it's important to instruct them on the following: consuming a diet low in sodium so they don't hold on to more fluid, consult with the provider regarding diet restrictions, and restrict fluid intake. So this is the only time I'm going to say to restrict it. Remember, we don't restrict fluid unless it's a known heart problem or a known kidney problem or some sort of actual reason. Like they have syndrome of inappropriate antidiuretic hormone. So we say restrict your fluids. Some of your risk factors, overdose of fluids, heart failure, fluid shifts that occur following burns, prolonged use of corticoid steroids, severe stress, hyperaldosteronism. Some more causes: water replacement without electrolyte replacement, SIADH, excessive administration of IVD5W, use of hypotonic solutions for irrigations. So what do these patients look like? Vital signs: tachycardia, hypertension. So you see that's the difference between them and that dehydration, is they're going to have both a very high heart rate as well as hypertension. And they're going to have that distended neck veins, neuromuscular weakness, visual changes, gastrointestinal, ascites. They've got that third spacing going on, crackles, shortness of breath, difficulty breathing, peripheral edema, low sodium levels. So these are all different expected signs we'd see with overhydration. Now, looking at all of this, you got to ask yourself, which ones are your most important? Respiratory, your ABCs. You always want to be assessing your patient at least every 2 hours to see, are they getting better? What do my crackles sound like? So these are my laboratory tests. Remember that these extra fluids dilute the concentration of blood cells in the body. So you can have decreased hemoglobin and hematocrit, decreased blood osmolarity, decreased urine sodium, decreased BUN. Chest X-ray can reveal possible pulmonary congestion. So what are we going to do about it? Monitor your eyes and nose. Monitor daily weight. So this is the best indicator, especially for a client who's going home, to see what their fluid balance is. At the hospital, we're able to watch it a little bit better, but at home, we can let them know that, hey, we're going to watch your fluid. So weight gain or loss of 2.2 pounds in 24 hours is the equivalent to losing 1 liter of fluid. Monitor breath sounds. Once again, why? Because I want to see, do they have crackles? Monitor peripheral edema, maintain sodium restriction diet, maintain fluid restrictions if prescribed, and encourage rest. Patient-centered care, you want to monitor the client receiving diuretics, educating them on taking it in the morning, encourage the client to discuss the use of over-the-counter drugs, position them in semi-Fuller's or Fowler's position, and reposition to prevent tissue breakdown, especially if they've got a lot of edema. Use of pressure reducing mattress, and monitor blood sodium and potassium levels. So complications. One of the main complications is pulmonary edema that can cause severe fluid that can be caused by severe fluid overload. Manifestations include anxiety, tachycardia, increased vein distension, premature ventricular contractions, dyspnea at night, change in level of consciousness, restlessness, lethargicness, crackles. Once again, that's why I told you your number one thing to look out for: respiratory, crackles, because what we're trying to see is, are they getting so bad that a complication is this pulmonary edema? What we can do for it: position them in high Fowlers, give them oxygen, possible intubation, administration of diuretics, if blood pressure is adequate. All right, thank you all, and I'll see you in class next time.